Today we are going to discuss about different signs in chest X-rays. A thorough understanding of the structures which normally contribute to cardiomediastinal outline is essential in being able to interpret chest X-rays and localize abnormalities. We will start with antenated chest X-rays with structures that account for the mediastinal outline. This is the frontal view. On the right, we can see the outlines of right paratracheal stripe, superior vena cava, arch of azygos vein, superior vena cava, right atrium, and inferior vena cava. On the left, the outlines of left paratracheal stripe, arch of aorta, main pulmonary artery, auricle of left atrium, left ventricle, and fat pad are seen. This is the lateral view. In the front, there are outlines of ascending aorta, pulmonary outflow tract, and right ventricle. In the back, the outlines of left atrium, left ventricle, and inferior vena cava are seen. Air bronchogram refers to the phenomenon of air-filled bronchi being made visible by the opacification of surrounding alveoli. It is almost always caused by a pathologic airspace or alveolar process in which something other than air fills the alveoli. In this X-ray, there is dense consolidation peripherally in the right upper and mid zone. Air bronchograms are seen within the consolidation. Silhouette sign refers to the loss of normal borders between thoracic structures. The differential attenuation of X-ray photons by two adjacent structures defines the silhouette. The silhouette sign refers to the pathological loss of this differentiation. In short, it denotes that a mediastinal border can only be obscured by a pathology which is in direct anatomical contact. These are the silhouette signs in frontal chest X-ray. If the silhouette of right paratracheal stripe is lost, the site of pathology would be the right upper lobe. In this X-ray, the silhouette of right paratracheal stripe is lost, so the pathology is in the right upper lobe. If the silhouette of right heart border is lost, the site of pathology would be the right middle lobe. In this X-ray, the distinct silhouette of the right heart border is lost, so the pathology is in the right middle lobe. This is a good side-by-side illustration of the concept of the silhouette sign. The left image is a normal chest radiograph with the red line, indicating the silhouette of the right heart border and right middle lobe. The right image shows the same red line delineating where the silhouette should be, but is lost due to consolidation in the right middle lobe. If the silhouette of right hemodiaphragm is lost, the site of pathology would be the right lower lobe. In this X-ray, there is airspace opacity with air bronchograms, obscuring the right hemodiaphragm, in keeping with right lower lobe pneumonia. If the silhouette of aortic knuckle is lost, the site of pathology would be the left upper lobe. In this X-ray, there is left upper lobe airspace consolidation with air bronchograms. The aortic arch and opacity of consolidation has become indistinct. So, the pathology should be in left upper lobe. If the silhouette of left heart border is lost, the site of pathology would be the lingular segments of left upper lobe. In this X-ray, there is partial effacement of the left heart border due to consolidation in the lingula. We can predict lingular involvement due to loss of left heart border silhouette. If the silhouette of left hemodiaphragm is lost, the site of pathology would be the left lower lobe. In this X-ray, there is opacity obscuring the left hemodiaphragm, consistent with left lower lobe consolidation. Double density sign is seen on frontal chest radiographs in the presence of left atrial enlargement and occurs when the right side of the left atrium extends behind a right cardiac shadow, indenting the adjacent lung and forming its own distinct silhouette. In this X-ray, there is splaying of the carina with elevation of the left main bronchus, a double right heart border, and cardiomegaly. The features are those of left atrial enlargement. Although the entire heart is enlarged, a double contour is seen through the right side of the heart. The more medial line is the enlarged left atrium, shown with white dotted line, and the right heart border is more lateral, shown with blue dotted line. Hilum overlay sign is useful in differentiating if an opacity on a frontal chest radiograph in the region of the lung hilum is located within the hilum versus anterior or posterior to it. If the cause of the opacity arises from the hilum, the silhouette of the normal pulmonary vessels is obliterated. If the edges of the vessels are appreciated, this implies that the cause of the opacity is not in contact with the hilum and is therefore either anterior or posterior to it. This frontal chest radiograph demonstrates a large soft tissue density on the right side. It obliterates the normal silhouette of the superior vena cava and right heart border. Hilar vessels can be seen through the mass. The ability to visualize pulmonary vessels through the mass implies that it is located either anterior or posterior to the hilum, but not at the hilum. This is known as the hilum overlay sign. The water bottle signer configuration refers to the shape of the cardiac silhouette on erect frontal chest X-rays in patients who have a very large pericardial effusion. Typically, the effusion has accumulated over many weeks to months, and the pericardium has gradually stretched. The fluid, often measuring a liter or more, causes the pericardium to sag, mimicking an old-fashioned water bottle sitting on the bench. In this X-ray, there is markedly enlarged cardiac silhouette with sagging appearance of its margins on both sides, resulting to a water bottle configuration. Here you can see the annotated image demonstrating the water bottle sign. Third mogul sign refers to an extramogular bump along the upper left cardiac silhouette, just below the left main bronchus. The third mogul sign commonly represents the enlarged left atrial appendage, particularly in patients with rheumatic heart disease. Other causes include cardiac aneurysm, pericardial cyst, coronary artery aneurysm, mediastinal tumor, pericardial defect, sinus of Valsalva aneurysm, and dilated right ventricular outflow tract. This diagram is showing the anatomy of the cardiomediastinal silhouette with the corresponding mogul on the frontal chest radiograph. First mogul is the aortic knob. Second mogul is the main pulmonary artery segment. Third mogul is the dilated left atrial appendage. Fourth mogul is the left ventricle. And fifth mogul is the prominent pericardial fat pad. In this X-ray, there is cardiomegaly with double right heart border, prominent left atrial appendage and pulmonary outflow silhouettes, splayed carina. This is the third mogul sign. The walking man sign is seen on a lateral chest radiograph and is a sign of left atrial enlargement. It results from posterior displacement of the left main bronchus such that it no longer overlaps the right bronchus. The left and right bronchus thus appear as an inverted V, mimicking the legs of a walking man. In the left image, the size of the left atrium is normal. In the right image, the left atrium is enlarged. On lateral chest radiographs, an enlarged left atrium results to prominence of the upper posterior cardiac convexity and posterior displacement of the left mainstem bronchus, which is the walking man sign. Golden S sign is seen on frontal chest radiographs and resembles a reverse S shape. Although typically seen with right upper lobe collapse, the S sign can also be seen with the collapse of other lobes. It is created by a central mass obstructing the upper lobe bronchus and should raise suspicion of a primary bronchogenic carcinoma. It can also be caused by other central masses, such as metastasis, primary mediastinal tumor, or enlarged lymph nodes. This chest X-ray demonstrates increased density in the right upper medial hemithorax with loss of volume and shift of the trachea to the right. A mass is present at the right hilum. A right hilar mass obstructing the right upper lobe bronchus results in collapse of the right upper lobe. This results in a reverse S shape to the pleural edge. This case demonstrates the typical appearance of a golden S sign. This patient had a primary bronchogenic carcinoma at the hilum. Hampton hump refers to a dome-shaped pleural-based opacification in the lung, most commonly due to pulmonary embolism and lung infarction. While a pulmonary embolism is expected to result in a wedge-shaped infarction, the expected apex of this infarction may be spared because of collateral supply from the bronchial arterial circulation, leading to the characteristic rounded appearance of a Hampton hump. This chest X-ray demonstrates the Hampton hump sign, a dome-shaped area of opacification in the periphery of the left lower lobe. Juxtaphrenic peak sign refers to the peaked or tented appearance of a hemodiaphragm, which can occur in the setting of lobar collapse. It is caused by retraction of the lower end of diaphragm at an inferior accessory fissure, major fissure, or inferior pulmonary ligament. It is commonly seen in collapse of the left or right upper lobes, but may also be seen in middle lobe collapse. In this X-ray, there is elevation of the right hemodiaphragm. Juxtaphrenic peak sign is present due to its peaked or tented appearance. Luftsichel sign is seen in some cases of left upper lobe collapse and refers to the frontal chest radiographic appearance due to hyperinflation of the superior segment of the left lower lobe, interposing itself between the mediastinum and the collapsed left upper lobe. This frontal chest radiograph demonstrates increased opacity in the left mid and upper zones, with associated lucency surrounding the aortic arch. The left hilum and hemodiaphragm are elevated, compatible with volume loss. The lucency is marked with arrows. Continuous diaphragm sign is a chest radiograph sign of pneumomediastinum or pneumopericardium if lucency is above the diaphragm, or of pneumoperitoneum if lucency is below the diaphragm. Normally the central portion of the diaphragm is not discretely visualized on chest radiographs as it merges with the cardiac silhouette. If the diaphragm can be seen continuously across the midline, then this is highly suggestive of free gas within the mediastinum, pericardium, or peritoneal cavity. In this X-ray, there is increased lucency around the mediastinal contour and a continuous diaphragm sign that point towards pneumomediastinum. This is a large volume pneumoperitoneum with the continuous diaphragm sign. Fleischner sign refers to a prominent central pulmonary artery that can be commonly caused either by pulmonary hypertension or by distension of the vessel by a large pulmonary embolus. It can be seen on chest radiographs, CT pulmonary angiography, and MR pulmonary angiography. It is seen most commonly in the setting of massive pulmonary embolism. In this X-ray, there is cardiomegaly with prominent pericardial fat pads. Both pulmonary arteries are enlarged, especially on the right, with the impression of a hilar mass. Westermarck sign is a sign of pulmonary embolus seen on chest radiographs. There is focal peripheral hyperlucency secondary to oligemia, resulting in a collapsed appearance of vessels distal to the occlusion. The theory behind the sign is either obstruction of the pulmonary artery or distal vasoconstriction in hypoxic lung. This patient had CTPA-proven pulmonary embolus, which is not shown here. There is left mid and upper zone regional lucency, with truncation of normal left-sided pulmonary markings. The regional lucency with truncation of normal left-sided pulmonary markings is focused here. Chen sign is the prominence of the left basal pulmonary vasculature compared to the right, seen in valvular pulmonary stenosis. It is due to the asymmetric increase in pulmonary blood flow to the left lung due to preferential blood flow into the left pulmonary artery after passing through the stenosed pulmonary valve during systole. In this X-ray, the left pulmonary artery is grossly enlarged. The right pulmonary artery and hilum appear normal. The peripheral pulmonary arteries are more prevalent in the left base compared to the right. Egg on a string sign refers to the cardiomediastinal silhouette seen in transposition of the great arteries. The heart appears globular due to an abnormal convexity of the right atrial border and left atrial enlargement, and therefore appears like an egg. The superior mediastinum appears narrow and give the picture of an egg suspended by a string, hence the name egg on a string. In this X-ray, there is globular or ovoid appearance of the heart, with apparent narrowing of the superior mediastinum. This is an annotated image showing the egg on a string sign. Ginkgo leaf sign is a radiographic appearance seen with extensive subcutaneous emphysema of the chest wall. Gas outlines the fibers of the pectoralis major muscle and creates a branching pattern that resembles the branching pattern in the veins of a ginkgo leaf. In this X-ray, there is right anterior chest wall subcutaneous emphysema, outlining the pectoralis major muscle. When subcutaneous emphysema has this pattern, it is called the ginkgo leaf sign. Holly leaf sign refers to the appearance of pleural plaques on chest radiographs. Their irregular thickened nodular edges are likened to the appearance of a holly leaf. In this X-ray, there are multiple geographic areas of pleural calcification, including involvement of the diaphragmatic surface. More black sign is a normal finding in lateral chest X-ray and refers to the gradual increased apparent radiolucency or blackness of the vertebral bodies when proceeding from upper to lower chest. This is due to the increased proportion of the chest comprised of air-containing lungs over distal dorsal spine compared to the upper parts. This is a normal chest X-ray of a 50-year-old male. From upper to lower, there is increased blackness of vertebral bodies. When the air is displaced by higher attenuation material, such as consolidation, fluid, or a mass, then the lower thoracic vertebral bodies become more radio-dense. This is referred to as the loss of the more black sign and is also known as the spine sign. In this X-ray, there is a right lower zone opacity, which creates loss of more black sign, indicating its position in the posterior lung base. Snowman sign refers to the configuration of the heart and the superior mediastinal borders resembling a snowman. This is seen in total anomalous pulmonary venous return type 1 or supracardiac type. It is also referred to as the figure of 8 sign. In this X-ray, pulmonary vascularity is increased. There is cardiomegaly with prominence of the right ventricle. The main pulmonary artery is dilated. The upper mediastinal shadow is whitened with convex left border, resulting in a snowman appearance. This is an annotated image showing the snowman sign. SHMU sign refers to the appearance of a prominent rounded left ventricle and dilated aorta on a plain PA chest radiograph, giving the appearance of SHMU, a fictional cartoon character in the comic strip Lil Abner, which first appeared in 1948. This sign is indicative of left ventricular enlargement. This is an annotated image showing the SHMU sign. Nucleario V sign is a sign described on the plain film in patients with a pneumomediastinum, occurring often secondary to an esophageal rupture. It is seen as a V-shaped air collection. One limb of the V is produced by mediastinal gas outlining the left lower lateral mediastinal border. The other limb is produced by gas between the parietal pleura and medial left hemidiaphragm. This is a chest X-ray showing the V sign of Nucleario and suggesting a diagnosis of esophageal rupture with pneumoperitoneum. Vertical branch is shown with thin arrows and horizontal branch is shown with thick arrow. Spinnaker sign is a sign of pneumomediastinum seen on neonatal chest radiographs. It refers to the thymus being outlined by air with each lobe displaced laterally and appearing like spinnaker sails. In this X-ray, you can see bilateral spinnaker sign. Steeple sign refers to the tapering of the upper trachea on a frontal chest radiograph, reminiscent of a church steeple. The appearance is suggestive of croup, which should be obvious clinically. Croup, also known as acute laryngotracheobronchitis, is due to viral infection of the upper airway by parainfluenza virus or respiratory syncytial virus. This is an X-ray of a child demonstrating a steeple sign. Here you can see the zoomed image of the steeple sign. Thymic wave sign refers to the indentation of the normal thymus in young children by the ribs, resulting in a wavy border on chest radiograph. In this X-ray, there are minor bilateral parahilar inflammatory changes. Normal cardiothymic silhouette is demonstrated with evident thymic waves sign. This is the depiction of thymic waves sign.
Thanks for watching. You may watch other videos in this playlist. Also, don't forget to subscribe.